Can you see it?
I see it, but it's
Is it
small.
blurry?
It's
A
small.
little bit, yeah.
Yeah.
So yeah, so Steven's head, is that blurry? Or
This is a patient at the clinic.
this is
It's me.
Steven. Yeah.
That's Steven. Okay.
So Steven, you want to just give kind of your history a little bit?
So I have like a lumbar scoliosis. I had different listings. So this one I think is like a PI on the left and an AS on the right. And before it used to be the other way. So it was that's like the old one.
Yeah.
So that's like 3 years ago.
All right. So this is 3 years ago, and then this was how long ago?
That was earlier this year.
Okay.
That was probably only like, not even that long ago, probably like a few months ago.
Ooh. Doc, why do you think it changed so drastically? You can see on this side, it's pretty obvious, this right curvature down here. And then a year or two later, it's pretty obvious how it's so left now.
I'd have to see them side by side. I wonder if is the marker on the right side, the right side on both of them.
That's what I was wondering.
Yeah, it's right
Oh,
here.
wow.
Have you seen anything like that before, Dr. Marzel?
Well, no, I think there's something wrong with either the marker or how the films are turned.
That's what I was thinking too, because when I was looking at it, I was like, these are very, very different.
Well, they're like identical in the opposite direction, too.
Yeah.
Yeah, if you put them side by side, they would probably look mirrored.
I wish I knew how I could see if this works. No. Sorry, I don't know how to do that, but
Even like the angle of the pelvis, the obturators, everything looks mirrored, kind of.
Mm-hmm.
yeah.
Even the MD.
Yeah, I couldn't, for some reason when I got this disc, I wasn't able to do the line drawing for this one. This was already on the x-ray, but I wasn't able to do a line drawing on this one.
Where were the most
Yeah.
recent
Either that or
ones
there's
taken at?
terrific mouth positioning, but something got flipped or didn't get flipped, I think.
The glute looks pretty good for in line with the pubic symphysis, right?
Can you zoom in on that a little bit? Okay, and then can you go down a little bit to see the lesser tubercles or lesser trochanters? Okay.
It's a little smaller.
Yeah, it looks like maybe those films just got flipped.
Mhm. Yeah, because that's a yeah. Yeah, so did you say your history, Stephen? I kind of forgot. Sorry.
I mean, I just kind of basically said how I had lumbar scoliosis and
Yeah. And he said, go ahead, sorry.
yeah, it was. I mean, that was basically it. I mean, I had a surgery recently, so I was kind of more like laying down a lot more, and then I started kind of having a little bit more back pain, and that's why I went and had the X-ray done. So that was kind of what came up was this scoliosis. So
Yeah. And we had a break at I think it was S2. No, it was like this disc right here. This is where we had our break. And he said when we palpated that exact tubercle, it actually shot up to the pain that he had in his lumbars previously.
Yeah.
Mm-hmm.
And then we went to the A to P.
Hey, just curious, Marcos, which one's correct based on what you feel as far as the curvature in his spine? Which?
The new one.
The new one?
This one.
Okay.
Yeah, so this one right here. Yeah. for sure, no doubt. And then we also saw that actually S1, S2 were, no, it's hard because it gets blurry here, but it looks like there's a little bit of a wedge down here between S3 and S2. How these are straighter, and then S2 and S1 are kind of wedged and tipped this way. I don't know if you could see what I'm kind of saying. Do you see that, Doc, or no?
Well, I see that how the sacrum is inferior on the left. Is that what you're referring to?
Yeah, pretty much, because I thought at S3, between S3 and S2, there was a wider gap on this than it is here.
But you also have to look at the femur head. The left femur head's lower than the right one.
Mm-hmm.
So that could be part of the tipping on that left side.
Okay. Yeah, I see that.
Because even the apex of the sacrum is going to the right.
Mm-hmm.
It's like the whole sacrum is tipped down.
Yeah. I think I was on, let me see. Yeah, we were contacting S2. And we did it as
so that'd be the tubercle between 1 and 2.
Yeah. So we were contacting this one right here.
Okay.
And I have to see my note.
How did you set it?
Trying to remember. We had his.
You just put me in side posture, and you told me S3 is what you adjusted. And
I think it was S. I have to see my note. No, I think it was. It was either S. It might have been S3 actually. Yeah, because that's where, as we kept going down, the break and the tenderness was all the way down there at S3, and it doesn't look as posterior or as much of an open wedge, but that's definitely where we found all of our readings. And so I contacted S3 on with the left side up.
Mm-hmm. Yeah.
Because of that. And then we were just we were pretty centered on. We were just on the center of it. And then we went and we torqued it up.
Like a base posterior sacrum.
Kind of, yeah. But then I added a little bit of torque this way. Because I thought that there was kind of a wedge here when I was palpating it, more on the right side than the left side. So I kind of added a little torque to torque this right side of the tubercle up to S2. What do you think, Doc?
Well, can you blow that up a little bit?
Yeah.
Whoop, too much. So what's a little weird about it that you're going to have to figure out is, the inferior side of the sacrum is on the left. Looks like the lower femur head, before you do your AD calculation, your lower femur head is on the left.
Mm-hmm.
So that may be why the gluteal fold is over on the right. And then, so is that tipping, that scoliosis, being caused by that lower femur head? Or is it, if you look at L5, pull up to L5 and then closer, it looks like it's wedge shaped, like it's malformed, like the right body is longer than the left body.
Yeah.
So that might be increasing the look of that curvature there. The combination of the bone and the lower femur head on the left side.
Okay.
It just looks a little wonky there.
Yeah. Do you think that there's a little bit of an increase, just what I was kind of feeling when I was palpating and what I kind of thought I saw here?
Okay, so the next thing to think about then is if there's a wedge on those sacrotubercles, is that what's causing that higher side on that side, or is it because of, malformation? And then if you look at, you have to try to decide, okay, you want to be on the side of the sacrotubercle that would be the body side of rotation of that sacrum, like P-R or P-L.
Yeah.
But if you look at L5 and L4, scroll up a little bit, both of those are all the way up. Everything is PR.
Mm-hmm.
So that means the sacrum would have to be posterior rotated on the left side.
Yep.
So is that going to match or make sense that there'd be a wedge on the right side of that sacral tubercle?
Probably not.
You follow that?
Yeah. Would the wedge and the rotation be on the same side normally?
Well, like a PRS,
Yeah,
but
could it be like
it's not a vertebrae though. It's a sacral tubercle.
Mm-hmm.
So it's a totally different animal.
Okay.
So does it always follow that rule then?
Well, if you're having a hard time figuring out what the rotation of L5 is, you look at two things. You look at L4 is usually easier to see which way it's rotated by the look at the pedicles or the distance from the spinous to the edge of the body. And then the other thing to look at is sacral rotation. L5 almost never, ever rotates the opposite direction of the sacrum. If the sacrum is a P-L, then that means L5 is spinous rotation is right and L5 body rotation is left, just like the sacrum.
Right. Okay.
That was a lot of verbiage to that question. I hope that didn't confuse anybody.
No, that makes perfect sense to me.
That was some of the things I was going to talk about when I was going to go through some x-rays with you tonight anyway, is just talking about that. If things don't make sense, then you got to start thinking about malformation, and you have to start thinking about maybe malpositioning of the film too.
Mm-hmm.
Do you see malpositioning on this film anywhere? Any indications of that?
Well, we were looking at the gluteal fold, but it would make sense. The gluteal fold might be a little shifted to one side when the femur head is low on the left side, and the gluteal fold went the opposite way.
I don't know if the measured distance, but I have the actual numbers for that, and it's 7 millimeters.
What's 7? Oh, the MD?
Yeah.
MD is 7. Okay, so we'd have to know the ilium numbers to be able to figure out the torsion factor.
The left is it's a 239, and then the right is a 242, almost a 243.
Okay, so it's an AS on the left. Is that the ilium you would list based on what you see of L5?
Yep.
Okay. And then what is there any, it looks like there might be some INEX too, right?
Mm-hmm.
Right, so what's your IN?
So left is 116 and right is 112.
So they measured the width of the
Iliums?
yeah.
All right. But what
This
is
one
it?
was 116,
What
right?
what does it say from the sacrotubercle down through the pubic? That's what you want to measure.
I don't know if it had that measurement.
Yeah.
I think it was they measured the width of the ilias on the film that.
Okay.
But
Well, that may not always be exact the same, right?
Yeah, I think so. The EX side was on the side of the AS, right, Stephen? I'm pretty sure it's an AS3 EX4, if I'm not mistaken. Or something.
Yeah. Well, because I'm looking at the actual measurements on the film, so those should be on there. If you have the disc, they should be on there.
I can't see the disc on my computer because it's a Apple one, so I had to do it on a different computer.
Oh, okay.
See, to me, it looks like the left ilium is an IN, not an EX. Even in the obturators.
Yeah.
The EX obturator is bigger on the right. I'd say it's PIX on the right and ASIN on the left.
Isn't that a little weird though, considering that the ASI? So when this correction make this even lower, this femur head?
So let's say it's a married listing. ASIN, what does a misalignment do to the femur head?
Raise it.
Raise it. So if you're going to correct it,
Lower it.
Lower it. So it actually could make it shorter, couldn't it?
Yeah. So then what?
Well, it just depends what it does up here on the sacral base.
Mm-hmm. Yeah, and I put the left side up.
But you're not going to be able to put a lift in there because don't look at the scoliosis like at L3 and 2. Look at it down at L4 and L5. It's on the right side.
Mm-hmm.
You put a lift on the left side, you're going to create problems. So even if you make that femur head lower on the left side, I don't think you want to put a lift in there.
Yeah.
Has anybody ever talked to you about a lift, Stephen?
I mean, sort of, but not really. I didn't want to do it.
Yeah, I don't think you should. You'd be better off doing something with your arches. I don't know what your arches look like, but you'd be better off trying to fix whatever pronation you have going on in your feet to help that than to put a lift in there.
Yeah. I don't really know. I just started getting like weird back pain when I like first moved up to Daytona, which was in like 2018. And then we just took an x-ray and that's what came up was the scoliosis. So it might have, I'm not really sure.
These are taken standing, right?
Yeah.
Okay. So you adjusted the third sacral tubercle, and how'd that go?
That was on Tuesday.
Yeah. That moved. It moved pretty well.
Yeah.
And I usually have weird kind of like when I'm getting up out of bed or something or getting out of my car, I'll feel like it feels like my sacrum like cavitates a lot, like my SI joints. So I never really knew what that was. I don't know, just kind of felt like a lot of cavitations, but that's just what it's always done, I feel like. Kind of sounds weird, but that's just what I notice.
So where are you at as far as your symptoms after you adjusted the tubercle?
Not bad. I mean, had really only get some symptoms when my back like tightens up, say like if I go to the gym or something, but it doesn't really affect me that much. I don't have like too many symptoms, I feel like, other than what just feels like muscle tightness. So
okay,
that's about it. No like unbearable back pain where I can't bend over or can't go into extension or flexion, nothing like that. So
since you have that film up there, let's just see if you can come up with a listing for L5. See if we can just talk through that.
can we see the lateral? Marcos, please. Do you think it has a little bit of wedging on it?
It's a little posterior inferior, yeah. Not a lot, a little bit. But I think you're smart by starting in those tubercles, though.
Would you think S2 is more of the major than S3?
Well, visually it looks like it might be, yeah.
Yeah. But I mean, that's what I was thinking after I saw the x-ray, and then I went back to reanalyze, but S3 was really more of a I guess, had more things pointing towards it. But. And is this the hourglassing kind of from the wedging?
Well, that's the scoliosis.
Yeah.
So let's go back to the ADP and see if we can get a listing, just for the sake of trying to go through the process. So how many possibilities listing-wise do we have for L5?
A whole bunch.
12, don't we?
Yeah.
Yeah, okay. So we know it's P. What's rotation?
R.
PR.
PR, okay. And is there a wedge?
Seems like a little bit.
Like a PRS.
Yeah, so even look at the right facet joint. See how the L5 facet is much smaller than the superior articulating facet of the sacrum. And then when you compare the right L5 inferior facet to the left L5 inferior facet, you'll see the left is much wider, and you can't see that sacral superior articular facet hardly at all. So that way we know, yeah, it's PR. Even the spinous looks PR. The pedicle is smaller on the right than the left. It says PR. You look at L4, and it's definitely PR, both by the spinous and the pedicle. So that's why I think the sacrum's got to be rotated on the left side.
I think
I think L5 is malformed too. I think there's something wonky going on between the body of L5 and the sacral promontory on the base there.
Doug, I think it was a PL of 4, if I'm not mistaken.
Okay. Yep.
Yeah.
PL2.
Right, so we're saying it's we're all agreeing it's a PRS, right? By itself, just by itself. Now, we always have to consider, once we have an L5 listing, is it a special L5 listing, or is it just a normal PRS? So what is your thought process to figure that out? What did I teach you?
Wedge of 4.
What's the wedge of 4 doing?
Say it's R. I mean, on the right.
Yeah.
I said R.
I think so too, but look at the wedge of 3. What side is that on?
That's on the
Left.
That's on the left. And so visually, if you think 4 is open on the left, just like 3, you would want to make that a special fifth lumbar listing, wouldn't you? If the wedge
So
is
you're
on
only-
the left.
So
If
you're
the
only
wedge on
going.
the, go ahead, sorry.
Sorry. So you're only going up one segment when you're looking at the difference in the wedge and seeing the concavity and the convexity of it.
Of L5, yeah.
Okay.
L4 disc determines what you do with L5.
Okay. Does that apply higher up in the spine, or then are you looking at more the general?
Just right
Scoliosis.
there at L5.
Okay.
So you just do like a mammillary contact on that then? If you're trying to adjust L5 at least.
If it was a special fifth lumbar listing as a PRSM, yeah. But you don't have a PRSM. I'd keep you as a PRS. Because the wedge on 4 is on the right, just like the wedge on 5 is on the right. But L3, the wedge is on the left, but you still got to fix 5 PRS. You follow that?
Mm-hmm.
Okay. Did you do anything else?
No, that's all we did.
Okay.
Right, Steven? I think that was all we did.
You did S.
Oh, no, and we did...
You did T10, I think is what you told me.
Yes, T10, sorry. And we did T10. Do you want to see the lateral first, Doug?
Yes, please.
5, 4, 3, 2, 1, 2. Oh, yeah.
That was where you kind of pointed it and you're like, this is weird.
This one.
What does the upper thoracics look like?
It's kind of hard to. I don't know. Would it be better if I zoom in or out for that?
In a little bit. That's good.
Okay. Oops. Sorry.
What does the ADP look like between T10 and let's say T7?
There, just not zooming out. That's fantastic. There. 1, 2, 3, 7, 8, 9, 10. Might have been one too high, maybe.
See, that might be in the compensation.
Yeah, I think it's 11 or even 12.
We'll go back to the lateral again.
This is 10 right here.
Okay. Yeah, I think that vertebrae's problem is lower, like at L1, and then you probably would be better off if you go up and fix T7. That would be, I think, where the next subluxation is.
Right there. How it's the hard, like,
Yeah.
turn.
And then if you look at the A to P, that's where the next wedge is.
Uh-huh.
Like, if I counted right.
Yeah, right here.
Yeah. Because look how it stacks up from there.
Mm-hmm.
What does his cervical curve look like on the lateral?
No.
Can you blow it up a little bit? Pretty straight neck, yeah. I would guess his neck problem is coming from his 7th dorsal, maybe first dorsal, maybe.
Mm-hmm.
Did you find anything in there?
Like up here?
Yeah, T7, T1.
Yeah, we've done T2 before.
Mm-hmm. Yeah, you did that a couple times.
Yeah, we've done T2, and then I think I did have a break a little bit higher than T10, but I went with the lower one.
Okay.
But I didn't
That's
get
fine.
anything really down here. When I got this break, I was just the shape of this body. How, I don't know what your thoughts of it were.
Can you blow that up a little bit?
Just the superior end plate.
Yeah, I think that's just a notochord end plate deformity.
Okay. Yeah, maybe I'll have to go a little bit. Either it's 7 or you said 2, right? Or 1. This one. L1.
I thought L1, yeah, that one.
Yeah. Yeah, you
Good job.
can see the wedge on the left and how it changes. Then that stack happens until 7.
Yeah.
And then that stack goes up. Mm-hmm. Okay. Thank you for the help.
Sure.
Yeah.
It's fun to have the patient right here so you can ask him questions.
Yeah.
Did you want to share, Doc?
Yeah, sure. I can go through. I've got about, let's see, about 15 to 20 sets of films I can go through, and I can go as long as everybody wants to go. If you get tired or fatigued, we can stop at any time.
I think we all need some good practice of knowing how to read a film.
So I should turn my camera on and then hit share screen. Is that what I need to do?
You don't even need to turn your camera on if you don't want. It's up to you. But you just need to share your screen.
Okay. Can you see those films?
Yes.
All right. So all I know about this patient is it's an older male, and we'll start in the lower back with them up together. What's the first thing you see?
Hip replacement.
Yeah, right hip replacement. So that changes things, right?
Yeah.
What else do you see?
What is that white? Is that BB in the?
Yeah. If you see on the A, the lateral angle.
I think the bigger artifact is probably like on a mole or a scar, and I'm guessing that smaller white spot would be maybe where he or she was getting their break.
Okay.
On the lateral, I kind of see that. I don't know if that's like
See it right there?
scoliosis or something. No, I'm talking about like L3,
Okay.
like right there. Yeah.
Yeah. There's a lot. So let's just start down low. So there might be a sacral segment here, right? One possibly between 1 and 2 and between 2 and 3.
Mhm.
The L5 is posterior inferior. L4 is posterior inferior. L3 is posterior inferior, really bad. 2 is posterior. It's got looks like an old avulsion fracture here, compression. And look, he's got a sclerotic abdominal aorta there. See it?
Crazy.
Doc, what's the calcification on the pubic symphysis? Is that a little overly calcified, you think?
On the A to P?
Yeah.
You mean you're talking about the whitening?
Yeah. Urination, kind of.
Well, it could be the tipping of his pelvis too. You see more of the bone. What the people that aren't in Gonstead would call this an AS, a bilateral AS. So you're going to see more anterior tippage, and so you're seeing more of the bone. I think you're just seeing overlying bone there.
Okay.
What about his ischial tubes? Like what's going on there? They look weirdly shaped.
Well, that's where they did all that shaving and carving of bone away.
Oh,
You're
okay.
talking about the greater trochanter?
No, the right.
Oh,
The
here?
ischial tubes? Yeah.
Yes.
Well, he's an older guy, so, those old hamstrings have been pulling on those ischial tuberosities, right? Plus a lot of sitting. There's a nice screw. So let me make a comment about artificial hips when patients come in. So you're trying to figure out AD and MD with an artificial hip. Is that possible?
Yes.
Well, yeah.
It's more difficult, but it's possible. So what you don't want to confuse the top of the artificial femur head with the top of the artificial socket. This is the socket. That's the head. You see what I'm talking about?
Yeah.
Okay. Then you can figure out your MD, AD.
Dr. Meisel, the artificial head looks like half the size of the normal head.
Yeah, it is.
Is that going to throw up the measurements quite a bit, or do you just do it anyway with that and take what you get. Like
that's what you have. That's what you have. Yeah. And so if you think you need to take a new picture after you've corrected the ilium and you're trying to make sense of it, take a new picture. Or if you think they need a lift, take a new picture. But this guy, you would never put a lift in him. His sacral base is pretty level.
Okay, thank you.
Doc, can you just kind of talk about maybe side posture with this patient real quick?
Well, it depends what we're gonna do with him, right?
Mm-hmm. I just know some people are kind of scared to wouldn't put this patient in side posture just because of the implant or whatever.
Yeah, I never had that attitude about it. If I've done it with single hip replacement, bilateral hip replacement, both push and pull, but it's certainly modified in how I do it. And of course, you can also do anything on the high-low.
Mm-hmm.
It's a matter of touch and stabilization, and just isolating what you're trying to move without involving that hip.
Mm-hmm.
You've said to put the hip replacement side up, preferably. Was that right?
Yeah, unless you've got a bilateral.
Right, and that was my next question. So, do you put the newer side down then, and the older side up, or how do you do that?
You might have to just experiment with the patient and lay him down on one side, ask him how that feels with the setup, and then bring him up, lay him down on the other side, and ask him how that feels with the setup.
So, would you get into the full position and just before the thrust, and then ask him?
I would see if I could get him in the position, if I could apply pressure, with my stabilization leg, just kind of talk them through it. So they, because you want them to know what you're going to do, because they might be nervous about it too. So you're showing them how supportive and light it's going to be. So, but like I say, if you're not comfortable with that, you can always put them prone on the high-low.
Right. Okay. Thank you.
And your stabilization is more of just a hold as opposed to dropping down on the patient, right?
I'm not going to get on the greater trochanter. I'm going to be on the thigh.
Mm-hmm.
I'm going to try to have my stabilization going more into the pelvis than rather than into the acetabulum.
Okay.
Let's see if we can get a listing on L5, and then we can talk about how I might fix it. Because once you know the listing, that might make more sense to you. So we know L5 is P. Is it right or left? Rotation. What's 4? What's 4?
It's R.
It's R. Okay, so I don't have lines on this, but it looks like the side of body rotation or of the sacrum would be on the left, doesn't it?
Looks like an IN on the left.
Yeah.
So that would make L5 a what?
PR.
PR, and then cover up L4 with your hand. Don't look at L4. Whoops, sorry. So see if you can cover up L4 with your hand, and then just look at L5. Is there a wedge on 5? And if there is, what side is it on?
On the left side?
Let's say right.
That's what I'm thinking.
Or if any. Not really much. More right, maybe?
Look at the transverse processes at the top where they meet the body, and then look at the transverse processes at the bottom where they meet the body.
It's the right side.
Yeah, the right side. You see the gap in there?
Looks wider on the right, doesn't it?
Mm-hmm.
Yeah.
All right, so we're going to call that a what?
PRS.
A PRS. Now, is it a straight PRS?
Gotcha.
Well, let's look at L4. Is there a disc wedge on 4?
Yeah.
Mm-hmm.
And what side's it on?
The left.
Okay, so what would be your listing?
PRS-M.
PRS-M.
Doug, where would you place BBs so they wouldn't get in disc space? Would you just try and put them over, like, I know that's a mole probably, but wouldn't you want to see the disc space?
Preferably, yeah. When we get done with these films, I do have them with lines on. They're not lines that I drew, but be curious to see if they come up with the same listings that we do.
Mm-hmm.
Because I think a lot of people are going to call that L5 a PRI-M, don't you think?
Yeah. If you don't cover L4, it looks like it.
Yeah. So we'll see what they did. Let's move up. You know, this guy's a mess. Look at his L3, right?
Mm-hmm.
Well, that's definitely should be listed, right? The way that looks on the lateral.
Mm-hmm.
So how would you list L3? 5, 4, 3. How would you list L3?
Is that a PL?
I think it's PRI.
So if you cover up L2,
That's what I'm doing.
what does it look like?
It's a little hard to see the pedicles.
Yeah, there's gas in the intestine, isn't there?
Yeah.
So, well, we know 4 is PR. What does it look like on L2?
Looks like
No.
It looks like it might be going the other way now, doesn't it?
Yeah, it looks like a PL.
The pedicle on the left looks smaller on L2. So this L3, rotation-wise, is in transition.
Mm-hmm.
And what side would you say the wedge is on 3?
The left.
Left, definitely.
But what about L2?
The right.
On the right.
The right. So that's a tough one to list.
Did you just try and stay on the spinous? For the most
So
part?
yeah, so if you look at the lateral, what's the biggest problem with L3?
Posterior, inferior.
Yeah, right here.
And that kind of happens with, I think,
What was the question?
well, it kind of looked like that was happening to like L2, I think, or L1. If you look on the lateral, like you kind of see the disc is forward,
Oh yeah, that's bad too. This
and even the
one's
one
bad.
above it.
Yeah, 12. Yeah. Yeah, so this guy in this area, in this lower thoracic, upper lumbar, you can make a case for about 4 or 5 levels. So it pretty much comes down to, you know, where you think the primary ends up being by your scoping, and then just keep watching it. You may have to, you know, move around a little bit from visit to visit occasionally, but you know, you're going to be spending a lot of time in here.
Do you think he has arthritis in there?
Oh, that's what that is.
Yeah.
Yeah, that's disc degeneration. degenerative arthritis.
What about at the facets?
Yeah, they look like increased whitening there.
Hey, Dr. Meisel, on the L1, T12, they're on the anterior of the bodies. Those osteophytes look like they've connected.
Yeah.
Would that change how you'd adjust those segments?
No, they're just going to be stiffer. I've
Okay.
got that. You can move them.
Okay.
Dr. Meisel, in this case, could you take like a flexion or extension film to see which one is like really fixed and which ones might be compensating?
You know, more information more information is not a problem. If you want to do that, if it helps you figure out what you think the primary is, then by all means do that.
Okay.
Wouldn't you trust your scope more than anything with this type of patient, though, considering you can make a case for everything structurally?
Right. That's what I'm saying. Follow your scope.
Good question.
Let your scope try to let your scope try. You know, another thing you can do. Let's see if I can do this with the film here. Turn the films horizontal. You get a totally different perspective then of where that most posterior segment might be. Right? As you're following George's line here. Look at this one. I would imagine you're going to find pressure right in here.
Mm-hmm.
I can see fixing 12 as part of the problem. One does. I mean, like I said, they all have posteriority, so you just got to find the major.
Doc, is this a good example of a case that you're not trying to make structurally perfect? You're more trying to just, with kind of that Dr. Rindle discussion?
Yeah, exactly. Yeah, your job is not, at this point, is not to, change curves to the point where you think you're going to make this big structural change. It's more about function and stopping the progress of that. But this is a really good thing to do with all your laterals. Turn them horizontal. And that's going to help you see the plane line of the disc, especially on those upper dorsals. If you're going to fix an upper dorsal, how you would send that vertebrae.
Can you see like ankylosing spondylosis, son?
Yeah.
Probably not this guy. He's probably just got like a whole bunch of arthritis. But like if somebody,
this is degenerative arthritis. Let's look at the mid dorsals. See, he's got more of that. Calcification along the anterior longitudinal ligament.
Do those vertebrae look like they're moved anterior quite a bit?
Well, if something looks anterior, that means something lower has to be posterior.
Yeah, yeah. That's what I'm saying. They look unusually. Or something looks unusually posterior then, right there at that transition.
Well, remember, this is on the lateral. This is where it gets stitched. So
okay.
there's overlap here, so that looks a little wonky in there.
Gotcha. Okay, that's probably what that is then.
So, and the first thing that I do on a full spine film, both the ADP and lateral, I number each vertebrae so I can figure out in this transition, this stitch area, is it T7 here and T7 here, or is this T7 and this is T10? You know what I mean? There's that overlap there, and so you've got to count from the bottom up and the top down to see how it comes out in this stitching area.
Doc, Johnny asked, how do you see compensation on a film?
Well, you start thinking at the base. The base should be level. So the first disc wedge from level would be your first subluxation. So the next disc wedge, then it will actually, after you see that disc wedge, you might see some stacking of 2 or 3 segments in a row of the wedge on the same side as the subluxation, but then all of a sudden you'll see the compensation. So the next wedge on the opposite side probably is going to be the compensation. But you never adjust off of the A to P. Remember, you always got to go back to that lateral and look at that disc space. And if it's not showing you that it's posterior, then you don't want to touch it. And you probably won't. You probably aren't going to see any kind of instrumentation there either. You might see a lot of heat around a compensation, but you're not going to see a break.
Kevin asked, do you think the patient moved before the film was taken? Or is this normal because the head is tilted to the right side there?
Well, his gluteal fold is quite a bit to one side, so he may be malpositioned a little bit. But his pelvis is pretty well centered here in the center of the film. He's pretty well centered there. And I don't see that his clavicles are overly tipped one way more than the other. They look pretty level there. This one's a little higher. Looks like the one on the left. So then he's tipping his head up on the left, so he's compensating for the low shoulder on the left. I think that's normal for him.
Did you see that? Oh, never mind. Sorry. Kevin asked if you can give a C2 listing for this patient. If you would list C2.
All right, well, let's just talk about it. What does the overall cervical curve look like?
Not horrible.
For his age, it's not horrible, and his discs, nice and thick. He's got some decent disc space, right?
Mm-hmm.
So, but do we see anything though? We see that his neck is straight here. See it stack and kink right there? What is that, C5, 2, 3, 4? That's C4, C5. The disc on 4 is better than the one on 5. So there's some posteriority right there. So whether or not even 6 is a little posterior, but it's still a pretty good looking disc there. So if I don't get an instrumentation reading in here, I'm not going to touch it. But I would list C5 long before I would list C2. C2 does look a little posterior, but it's at the top of all that stacking.
So, do you think there's any malformation between C2 and C3? I don't know if it just.
I think you're seeing that head tilt. That's what I think you're seeing.
Oh, okay. Because it just looked. I don't know if it looked weird on the lateral.
Yeah, I think what you're seeing. I know what you're looking at. You're looking at right through here.
Yeah.
That's because his head is tilted.
Mm-hmm.
Somebody was asking about that, right?
Yeah.
Got that head tilt there. That's that compensating head tilt. But if you had to list C2, okay, I'll give you the possibility. It's a little P, but it's it would be, you know, low on my list because all of this is stacking below it. If I go to the A to P, everything looks PR below it, but the wedge is on the left, so PRI-L on C2 if I had to be forced to come up with a listing.
Yeah, Doug, can you also, if you see a PR C2 and then a, say, ASRA at C1, are you more inclined to pick C2 because of the rotation and the atlas following it? Or if you were thinking of an upper cervical problem, I know that's not this patient's case, but if you were thinking about it, would you think C2 would be more the primary because C1 follows the rotation?
So you're saying the body rotation of C2 is on the same side as an anterior rotated atlas?
No, the spinous rotation is on the same side of an anterior rotated atlas.
Oh, okay.
So like a PR and then an ASRA.
Okay.
Would you think that the C2 is the cause of that and the C1 is compensating because of the rotation? No.
Well, remember, we always go back to what does the lateral say?
Mm-hmm.
So if it's a really posterior inferior C2, I would unless the symptomatology and the palpation said something totally different, I'd adjust C2 before I'd adjust the atlas.
Okay. I know that wasn't for this patient. I was just thinking in general while we were on the topic. And you also mentioned if you had a reverse curve in the neck.
Yeah.
And the atlas presents a certain way, it's a compensation, but if it presents the other way, it could be a subluxation.
Was I referring to the AI and AS?
Yes.
Yeah, so typically this is what looks like an AS, right?
Yeah.
An AI, then the posterior arch would be up and the tubercle would be down. Sometimes you'll just see it kind of sitting right in the middle, looking like it's not AS or AI. And that would be making you think compensation.
Okay.
But you usually see an AI with reversed cervical curve.
Okay. And then that's telling you that it's probably something lower because it's just following the curve.
Right. If you had to get a listing off of the atlas there visually, what do you come up with?
ASLP. Maybe an A, actually.
Yeah, it looks like the left side is more forward.
So the lateral mass on the posterior rotated side, is it larger or smaller?
That's where I'm having.
It's smaller on the posterior rotated side.
Smaller on the posterior side. Okay, so what will how do you get your right and left?
The
wedging.
Wedging, right? So this joint space right here.
Looks bigger.
So which side looks a little swollen?
The right side.
The right side, okay. And then
So
what does the lateral mass look like?
Looks larger. I'd say
Looks
anterior.
larger. So what would be your listing?
ASRA.
ASRA. We'll see what they come up with. How they did it.
Doc, is that a little contradicting though with the way the head's presenting?
Doesn't the occiput go up higher on the PS side of the occiput?
Mm-hmm.
Yeah. That's why Gonson said 85% of what you see in misalignment in the upper cervical is compensation.
Mm-hmm.
I know upper cervical people don't like to hear that, but that's how he felt. So he would always say that go by more your palpation upper cervical than by off the x-ray for your upper cervical listing. But really the key for that is what does the cervical curve look like? Even if you get some symptomatic relief by adjusting the atlas in a reverse curve, chances of it ever stabilizing are not as strong as if you would just leave it alone and work on the most posterior segment. Because remember, if it's a parasympathetic problem, it goes all the way down to C5 disc. Let's pull up the line drawings on this one.
You were right. About 5.
They did list a PRIM, didn't they?
Yep.
And they listed L2 instead of L3, probably because they weren't sure what to do with L3 because of the way it looks on the A to P. But L3 definitely looks more subluxation potential than 2. And they didn't list 12 or 1. Looks like they listed 9, or they.
Is that what those like crosses are? Is they're saying that there's a subluxation there?
I don't know. I don't know if that's just something that happens normally on digital. If that's something part of digital films, or I'm assuming this is digital.
I'm not familiar.
Yeah. If anybody knows out there, just go ahead and speak up. Because that would not be a marking that would be done on an analog.
Yeah, it definitely has to be digital, but I don't know what program that is.
Yeah, you can make your own lines in the digital, so that's probably what they're doing is marking it as posterior, probably.
Okay. Look what they did with the atlas. They thought the wedge was on the left because of the tippage of the head, didn't they?
So they said what you said, ASLP.
But we said it was an ASRA.
Yeah.
Yeah. They did not list. Here, look, they drew the lines on the lateral cervical. Right, those disc plane lines. Right, so look where they're crossing. There's C5 right there.
Yeah, short.
See, look at the disc space. If their lines are right, look, you see how open those are in the back between 2 and 3?
Mm-hmm.
Yeah, that's not something you probably want to be moving. It's a little foggy in here between 7 and T1 to really know if they got the right angle on that one. But I think they got it right here on between 5 and 6.
So then you were saying they should adjust C5?
No, I didn't say that. But I would be depending on the symptomatology, right? I mean, this person probably could handle maybe a few times on C2 if there's symptomatology allowed it, but long term, this is not where you want to be. You want to be down here.
Uh-huh.
If the symptomatology is there, wouldn't you be more inclined to go C3 instead of C2?
It looks more posterior, doesn't it?
Yeah.
You know, that's the day you say I'm a doctor and you make a decision and then you write it down what you did and then your next check, your best check is your next visit.
Mm-hmm.
Ready for another one?
Let's do it.
All right. How are we doing on time?
Good. It's only 7:15.
Okay. I haven't lost anybody yet, have I?
No.
All right. Here's another good one. We're picking on old people today.
Not the first one. The first one would be.
Oh, well, first one I had. So here's a male, older male. Look at that lateral.
Some more like spurring.
Looks like there's some old trauma there, doesn't it?
Yeah, but I was thinking more of like on the anterior portion of the bodies.
Yeah, don't worry about that stuff. It's the stuff back in here in the IVF. That's the stuff you got to worry about.
Yeah.
Does that posterior inferior end plate on L4 look compressed?
Yeah, it looks like an old compression injury.
So it's really inferior then if it's that close
Yeah.
down and compressed.
I mean, L5 looks a little posterior inferior, but 4 really is. So, and he's got a BB here and a BB here, so I'm going to assume that this big one is a scar. And that's sitting right on top of the L4 spinous on the lateral. And there it is right there. Because there's L5.
Dr. Mizel, could L5 be a spondy at all? Because it's the discs are both open in the anterior, and is it?
No, so because that anterior part of the body is not past the base of the
Okay.
sacrum.
Okay.
Yeah, it's not past that, so that's not the problem. There is maybe a sacral segment here. All right, so L4 looks nasty. On the A to P. Pretty good positioning, right? There's the gluteal fold going through that symphysis pretty close. The lesser trocanthers look pretty close in size.
Doc, I've heard sometimes that the lesser trocanthers can be affected if there's an ilium misalignment. Is that what you saw or not really?
I just look at them mainly for positioning.
Okay.
I don't try to determine a listing from them.
Okay.
So visually, you know, I don't have any lines on here, but if we were just to look at the obturators, the vertical length obliquely, which side would be the PI side?
Left. Right.
It's close, isn't it?
Yeah, obliquely the right.
Yeah.
Close.
The top of the left crest is higher than the right, but it's not as long at the ischium, so it's, you know, that looks like that would be maybe the AS side. How about INEX?
Iron on the right.
Yeah, it looks smaller widthwise in the right, large, so looks like we're going to have maybe a mixed listing here. That's why it's hard to visualize there. Let's look at the sacrum and L5 there. Would you say L5 is rotated PR or PL? Assuming that the right is the right. Okay. How would you list 5? Rotation.
Let's get PL. Maybe PR. Pretty close.
What's PR? I mean, what's L5 or 4? What's L4?
That's PR.
What's L3?
That looks PL.
PL?
L3 looks like PL. All right, so we don't have a lot of rotation going on. So what's another thing we can look at? We can look at the pedicles. We can look at the inferior articulating facet. So this film's, the quality is not so great, is it? So that's always an issue, right? This guy's got a big belly on him. See that big belly hanging down there? So just always be aware of that when you're taking the films. There's nothing more frustrating than you can't read it because you didn't get the technique right.
A little more radiation.
So the next thing for me to do is if I'm just not, I don't trust myself with what I'm seeing here, I would then try to, you want to go to the sacrum then to see if you can get rotation off the sacrum, and then that might help you decide what L5 is. And again, because it's so light in here, it's really hard to, looks like maybe right there is the edge of the right sacrum. And on the left side, it looks like maybe right there. There's, looks like the joint space right there coming up.
Could this be the break also be from a PI, since you said the PI looks like it's on the right and it's at the top of this joint?
I wasn't even thinking that far ahead.
Oh, sorry.
That's all right. I'm just trying to make sense of the film based on the film of what it's presenting to me to help me decide what to list.
Mm-hmm.
So we'll see what they come up with. Let's just say that 5 is PR. Is it PR what? What side do you think the wedge is on 5 if it exists?
Left.
Looks like it's left. It looks like it's left side. So is that a PRI or a PRI-M?
A PRI-M.
So do you think there's a wedge on 4?
Yeah.
Okay. And you think it's on the left?
Yeah.
Okay. So you're going to go with PRI-M then? That's fine if that's what you want to do.
What are you thinking, Doug?
Well, 4 is open on the right. So I think you could still get away with a PRI-M on 5 as long as you don't, on a public bench, if you're doing an involved side up, as long as you don't twist the patient and keep them straight so you don't involve this right side of L3.
So do you think 4 is a, what do we say? Do you think 4 is a PRI spinous, you said?
I didn't say that, but I think there's malformation going on right here.
Okay.
But I think I do want to be on this left side. All right, let's move up. There we go. We got some nice spurring going on. Hyperkyphosis.
A little bit of a scoliosis.
Got some curvature here. So I think T12 is compensation. This one right here. 5, 4, 3, 2, 1. Yeah, T12. I think that one, that wedge on that right, that's compensation for what happened down here. And the disc wedge on 12 is pretty level.
So, Doc, how do you decide whether it's compensation or not if it's on the opposite side, if the wedge on the opposite side of where the normal wedge starts? Then
I go back to the one that looks posterior on the lateral.
Okay. Because 12 looked like it had a thin disc, right? Or
yeah, but it was parallel.
Oh, okay. So you didn't think it was like a D5?
This one?
Yeah.
Well, I mean, it is a thoracic disc, so it's going to be thinner than a lumbar disc anyway.
Mm-hmm. Okay. Yeah. Thank you.
Yep. Here again, he's underexposed through this heart shadow is covering everything up here. It's hard to see pedicles in rotation there. But it looks like if we were going to count down, see how C2 on this one, nice thick disc, but it looks a little open in the back. Compared, you wouldn't want to touch that one. You wouldn't want to touch this one because look what's all going on below it. Look at that. Look at that stacking kink right there. And then at the bottom, look at all that degeneration. It probably starts right here. He's got, it looks like maybe a reading there, here or here.
Do you think there's something going on where thyroid is? I just don't know if that looks normal or not.
I think it's all right. It may not be all right functioning wise, but. So do you understand why we wouldn't be interested in what's going on up here? C2, 3, and 4.
Mm-hmm.
Even if they say their neck hurts there, that's not the problem. Down in here.
What do you think, like T1, 2? Let's see.
Well, he's got stacking going on from there.
Uh-huh.
Here's T1, first rib. You want to list T1? Go ahead.
Well, do you think that's a compensation for T2 since T2 looks a lot more
Where's the kink though? The kink is right
at the base.
Looks to me like the kink is right there.
Uh-huh.
Stacking here and stacking here. This looks like where it meets.
Okay.
And so to help this problem, then you also need to be down in here. You need to be down. See if we can figure out which one that one is.
Changes there.
One.
So, Doc, you normally list the ones that are in the middle of two stackings, kind of?
I'm always looking for something in the transition.
Okay. So the
between kyphosis and lordosis. You know, you should find something between cervical thoracic and thoracolumbar and lumbosacral. You know, those transition spots, that's where people get in trouble.
Mm-hmm.
So it looks like I might fix or list T7. Let's take a peek here on the A to P. 1. Looks like it starts at 8 though, doesn't it? So maybe we want to list 8 then. Yeah, that's a close one. So, you know, you just have to list one. They're going to have the same listing, although there's more rotation, looks like on 7 than there is on 8. And it looks like maybe even the body of T7 is malformed, like it's higher on the right than it is the left. That might be making that appear worse than it really is.
You're saying like the vertebra is actually like basically squished on that side?
Or it's wedged. In other words, the actual height of the bone is higher on the right than it is the left. Do you see that?
Yeah, like the vertebral body's like actually smooshed.
Longer. It's long. It's wider or longer on the right, and it's shorter on the left. And that's why the scoliosis takes off that way. Let's check the lines on that one. Look what they did. So this listing makes no sense with how they have the sacral rotation. Do you see that?
Mm-hmm.
Yeah.
L5 spinous should be the opposite side of sacral rotation. So if they legitimately believe that this is a PLS, then the sacrum can't be posterior rotated on the left.
I didn't even notice there was an L6.
Yeah, let's count and see if that is true. So there's the 12th rib. 1, 2, 3, 4, 5, 6. So it's actually not L4 here that looks so bad, but it's L5. did see the sacral tubercle.
Can you tell that by like the length of their sacrum?
No, because that L6, it looks like a lumbar. It doesn't look like sacralization, right? And you could count, if this was open, collimation was open up a little bit more. There's S1, S2, S3, S4, S5, and that looks like that's the first piece of the coccyx. Yeah, so that has 4 pieces. So, yeah, that's a full normal sacrum. So that is a legitimate L6. I don't know that I would agree with that listing. But look what they're trying to do. They didn't keep it as just a PLS because they saw the disc was open on the right on L3, and so they're seeing that convexity over there. So they're thinking they need to be on that right mammillary. So a lot of it comes down to your palpation and the symptomatology of the patient. What they say the iliums were? They're saying the left one is PI, not AS, according to their measurement. And they're saying the left side is the IN side. They list T7. And they listed T1. We didn't really look at the atlas, but usually the lateral mass looks wider on the left, and the lateral mass is also smaller in its width, so ASLP, I wouldn't argue with that. Any thoughts or questions on this one before I go to the next one?
I don't think anyone does.
Okay, let's change gears. Let's go to a young person.
How old do you think this person is, Doc?
I'm going to say an adolescent, maybe in that 10.
Mm-hmm.
Well, it doesn't even look like their sacrum's fused, so they gotta be pretty young.
Yeah. So what do you see on there?
Gas.
Looks like a spondy.
Yeah. Look at that. And we're not supposed to take X-rays on young people because they don't have problems. Do you think it would matter that we would know that?
Yeah.
Sure.
Do you think the average chiropractor is going to be able to palpate that?
Nope.
Posterior.
What?
It's posterior L5.
Yeah, well, yeah.
That's spine inspector.
The spinous is.
Yeah.
Yeah, and that still would even be too high, right? I mean, you can make a case for sacral tubercle. Look at that one.
Mm-hmm. Oh, yeah.
That's crazy.
Wish we knew the history with these.
Well, it looks like there's a lot of gas and stuff in the GI tract.
Yeah.
But that could just...
So, I don't know if that BB is for a blemish or if it's for a break, but it's right over that that tubercle there.
Do you think this is probably like a young female girl? It's probably like a gymnast or something, or like into gymnastics?
I think this is a male.
Okay.
In fact, I'm sure of it.
Okay.
Yeah.
Yeah, look at so the way you tell by the bone is find the symphysis pubis, and female is going to have more of a wine glass appearance here, and male is more of a, let's say, champagne glass. As you can see the lateral, I thought I saw testicles there.
You can see in the HP too.
Yeah. So yeah, you would have thought if you just were looking at that lateral sacrum and that L5, and oh yeah, female gymnast, but no, it's a little boy.
Okay.
I wonder if he had some trauma, right?
Yeah.
Falling out of a tree or something. How about positioning?
It's pretty good.
Pretty good for a young kid, right? There's the gluteal fold. Yeah. And see all of this, that's just growth plate connections there. That's that's not fractures.
Yeah, it looks so weird. I never seen like a young.
Look at the greater trochanters there.
Yeah.
All right, so we found that. Look how nice and thick those discs are.
Parallel.
I miss those.
I miss them too. Oh, what's going on up there?
What is that? Calcification.
Is it?
Posterior conical? Or is that just rotation?
That's rotation. Look at the jaw. See how this patient's head is really tilted. Watch. Let's see the head tilt.
Mm-hmm.
Look at the shoulder height. So we don't know if the patient did that or if they actually looked like that. But to me, it looks like it's coming from the spine because look at the curvature in here.
Mm-hmm.
Yeah.
See, all that could be coming from down here.
Do you think they just couldn't get into the right position just because of possibly if they have pain?
I think it's pretty good positioning because the gluteal fold is on. So I think all of this is coming from that sacral area.
Okay.
So yeah, so you're seeing the top and the bottom, or the left and right side of that posterior arch there of the atlas, the ring.
Really?
Because the head tilt. Look at the jaw.
Mm.
If you see that in an adult, do you think that? What do you think when you see that in an adult too? Because I've seen some adult films that have that much.
Well, that head tilt could just be that's their normal.
Yeah.
I mean, if somebody I haven't that last one, the older person I showed you, he had that thoracic curvature, but that one for that patient's been there a long time. This kid hasn't had it that long. Let's see what their line drawings, what they did. They caught the spondylo. They were interested in all those sacral segments.
Another L6.
Let's count them. There's 12th rib. 1, 2, 3, 4, 5. There it is. Rib. How about that?
It looks like they actually wrote if they had a blemish there or not. So that's break, but the other one said freckle.
Yep. Yeah, so I think they're using the larger BB for skin landmark and then a smaller one for actual where they're getting their break. Looks like they thought they had a break at That'd be T10.
Mm-hmm.
But they listed 10. Yep.
Doesn't it look like down where that freckle is kind of the start of that scoliosis? At L3, L2.
Yeah, but I think that's compensation.
For like the L5, maybe?
I think it starts way down here in the sacrum.
Oh, yeah.
All starts down here. Because look how
could that change? So could that change since they're so young that if you try and correct that spondy, would it like fuse at all?
Well, it's going to change quickly. You get on the right bone on that sacrum, that could change, in 1 or 2 visits. You could take a new A to P, and after you fix that sacrum a few times, and I bet in his case, it would change because I don't see a lot of malformation of the vertebrae.
Jack, what would you contact if you were trying to address the L6, S1 joint space? Would you just contact S1 on a child, even though they're all individual segments? How would you fix like a spondy adjustment?
So on this patient, I'd be careful by being too high.
Mm-hmm.
Because he's got these posterior segments, I'd be more interested in working on those before worrying about this one.
Okay. But say those segments were fine, and you wanted to address that L6, S1 joint space. Since these aren't fused segments at all, how do you correct bring S1 underneath without affecting S2, 3, 4, say?
I guess you would look at it the same ways as how do you fix a normal L5 without bothering L3, right? I mean, there's still tissue in here. This isn't air,
Mm-hmm.
so you still can move it. You can still move it as a unit underneath.
Okay. I just didn't want to create like a...
Yeah, that's good thinking, but I don't think that's a problem.
Okay.
And I don't think I would have listed anything in his neck.
Looks really good.
So all those lines are, they're in the back, open in the back. I don't agree with his C3 line. I don't think. Again, it looks like a lot of rotation in this upper cervical C2 atlas area, but that's, we're looking at that as compensation for what started way down here.
Mm-hmm.
So if you're trying to, say, address this patient and they only came in with one complaint, you're not trying to say, and you think the complaint's related to the S3, say, you wouldn't want to even mess with T11 or the other ones that he listed if there are complaints down there, because you want to see what changes before you go up to there? Or
right.
Still do that for structural reasons?
Yeah. Yeah, I'm thinking the most, especially because it's a kid, right? So whatever they have, usually they haven't had for a long, long time. So all of this is misdirection for what's happening down here at the bottom.
Okay.
I think this is a pretty cool case. I wish we had some information on it.
Yeah. What do you normally see associated with S3 subluxations, bedwetting?
That could be one. Hyperactivity.
Okay. Do you really see hyperactivity like ADHD just as equally as the upper cervical as it could be a sacrum subluxation? Would you say?
Yep. I don't let one decide over the other. It could be both. It could be one.
Okay.
Is it like hyperactivity, as in like kind of just like not sitting down? You know?
Attention deficit disorder.
Yes, it just like, you know,
Or just any kind of CNS abnormality. You're always looking most of the time in the parasympathetic system. If it's something that chiropractic can help, it's going to be parasympathetic for that. Not all patients are going to respond the same, right?
Yeah.
There's other parts to those issues, but if any of it would be neurologically something that we could address by what we know, it would be, in my mind, I'm thinking parasympathetic, but I don't lock myself into that it's upper cervical. I don't lock myself into that it's the sacrum. I'm checking them both.
Mm-hmm.
And you would only do one, correct? Like you wouldn't do the S4 and an ASRP in the same visit for the sacrum?
No, not initially. Not initially.
Is there ever?
I know the sacrum is going to change the atlas, probably.
Mm-hmm. If you adjust,
if it ends up not changing the atlas, then I might go up and start tapping that too.
okay, so you would adjust the sacrum first, of course, and then you repalpate, and if it still feels pretty fixated, you wouldn't have a problem going after it, but if you're feeling it relax and move better, you're going to leave it.
Right.
Okay.
All right, let's do another one. Here's another child.
Seems younger.
This
Very
one's
young
younger.
child.
Yeah. Another little boy.
No spondies.
No spiny this time, but we got sacral segments, don't we?
Oh yeah.
Say S4.
Do you think that kind of happens a lot with like younger children because they kind of always tend to have the kind of like weak abdominals and kind of more of that like belly?
What happens a lot?
Kind of like more of like a base posterior, probably like spondy.
Well, a lot of adults have big bellies and they don't have spondylos.
Well, do you think that's from like fusing though? Like the discs are kind of more rigid than say like a child where it's more flexible?
I guess I'm not following your line of thought.
I would think it's from falling on the butt so much, trying to walk, learn to walk, and
Well, I'm kind of thinking that like they have a higher risk of injury because they're structurally not as strong as an adult.
But they're very flexible. They're really bouncy. Their bones are really pliable.
Uh-huh.
So, Doc, do you think that the reason why some older people don't have a fused sacrum is because they probably injured it when they were younger and they weren't fused like this, and then it never got addressed, so it couldn't fuse?
That's a good theory. I don't know if we can prove it, but that's a good theory.
Could it be fused and still have an open disc in one of the tubercles?
Sure. You could have the sacrum totally fused as an adult but still have one tubercle that's open just enough that it can create some problems.
But even though it's fused, you could still move that specific tubercle.
Yep, you can move it. Unfortunately, he's got a lot of gas too. So we're really covering up that lower segment sacral area.
Look at his femur head. It just looks like a nub.
Yeah.
Like a little mushroom. That's what it looks like.
A lot of cartilage in there. And look, for a young person, pretty darn good patient positioning. Looks like he held pretty still there.
Yeah.
What do you think about his neck?
It's kind of straight.
It's really straight for a child.
It's pretty straight for a child, and you think, well, is it because it's bad positioning? Does he have his chin down? Well,
Yeah.
looks like there's the hard palate. It's pretty level. It might be down just a little bit.
A few degrees.
Yeah. So it's not horrible positioning.
Could be.
So it looks like maybe that might be a freckle, but I'm just looking at the curve. Looks like maybe about right there. It's at T1.
Mm-hmm.
2, 3. Yeah, T1, C7. That there might be something happening right there. That he might need some work done on.
Could this one possibly be the atlas being, or the occiput being the way it is?
Well, we don't know a lot of symptomatology. We don't know anything, right? So
I'm just trying to think of, since they're so young and their curve looks that bad, unless they got in some really bad accident, this could be from birth. Grabbing the neck.
well, yeah, pulling and twisting on the head.
Yeah.
Yeah.
There's no break there, though. At least on the film.
Yeah, they didn't mark it. Maybe he only has one complaint.
Mm-hmm.
But the doctor's looking at it as the spine is an organ, right?
Mm-hmm.
Let's see what they do for their lines.
I feel like you probably still marked the atlas, though. Yeah.
If it makes you feel better, yeah, go ahead and mark the atlas. So it looks like they starred T1.
That is a break, not a mole.
And they've got a listing there. Let's see what they decided up top. They didn't really give a listing. They just put lines on C2. I'm not sure why you would do that and not list it, but look how open their lines are saying C2 is. That means don't touch me. Look at the atlas. It's tending to be an AI atlas, right? Because of the loss of the curve.
That occiput's really AS.
Yeah. And maybe he's got an AS occiput. That was for your question, right, Marcos?
Yeah.
Yeah. And that's what he listed too, so.
So how can you have an AS occiput with a reduction of the cervical curve? Isn't that kind of the opposite?
Mm-hmm. And an AI atlas compared to.
Yeah. That's where the scope and the symptomatology helps you out so much to try to figure out what's compensation and what's where your primary is.
His whole spine is kind of straight, honestly.
Yep. There again, it might be coming from all down here at the bottom.
Mm-hmm. And the ilium listing isn't a major ASIN either to make it that straight. It's pretty.
Yeah, the measurements aren't huge, are they?
No.
If we can trust them. That's the big if. I will make one comment about their lines. Their lines are way too thick. Your lines on your films need to be pencil, needle thin. Because you're measuring millimeters. You're not measuring.
Yeah, I think it looks like they're overlapping, where he did the top of the ilia and the.
Yeah, but look at that. Look how thick they are on the ischiums.
Yeah.
Yeah, those are like 3 times as thick as they should be.
Yeah, because I think the measurement goes to the center of the line, not the top of the line. And it looks like they did it kind of based on the top of the line, the measurements.
I've never measured from the middle of the line. I've always measured right where the dot is.
Yeah.
Right on that edge of the bone.
That's interesting.
All right, let's see. What else do I have here interesting? Number 4.
No curves. At a medial wedge of 5.
Yeah, it'd be good to know if this person's acute, right? Because the disc looks like it's swollen in the back, and it's also swollen in the back on 4.
Mm-hmm.
That's when we'd see that, isn't it?
Mm-hmm.
Positioning might be a little off there. Big wedge on 4, but boy, on the lateral, you wouldn't want to be touching it.
Mm-hmm.
Anything going on in the sacrum, you think? Maybe a small one right there. Not much, though. Pretty level.
Yeah, that's it.
So let's just say, for sake of argument, we're going to call that a medial disc of 5.
Yeah, doesn't the sacrum look straight too, with the spine, pretty much?
You mean this angle?
Yeah, like really vertical.
Well, it actually doesn't look too bad, though, does it? I mean, it's not hyperlordotic.
Mm-hmm.
It is on the hypolordotic side, though, isn't it?
Yeah.
Yeah, it'd be interesting to see if this person could extend, right?
Mm-hmm.
So there's 2 schools of thought on this with a medial disc bulge. Some docs will get on the sacrum like it's a base posterior. Other docs will just get on 5 on the spinous. So what do you guys think you want to do?
I want to check the ilium.
You want to check the ilium? You don't want to touch it, do you?
Well, I mean, it looks like everything's straight, and I'm wondering if that could be due to an ASIN if they're not acute.
So let's say they're acute, and you're convinced that it's this joint right here between 5 and S1. Are you going to do the sacrum or the lumbar, and then tell me why?
I think on this case I would do the lumbar because it looks posterior. The George's line looks further back compared to the sacrum.
Yeah, like right here.
Yeah.
Right here. Yeah.
So I would probably want to stay away from doing the ilium.
So you think it'd be better to set the sacrum like a base posterior or L5 on the spinous?
I would say L5 on the spinous for this case.
Anybody else? Okay, that's all right. So I think I'd want to stay on the spinous and just put pressure on it straight P to A. And are you going to be on the left or right side?
I would say the left, just because of the fours wedge.
The left. And how much of an adjustment would that be?
Say a pump at first. See what they can handle.
Well, what you could do is you could actually just get them either on the knee chest or just get them on their hands and knees on the pelvic bench, trying to get this to turn. No, it won't rotate for me. I'm not sure why.
There you go. Now you can do it.
Oh, okay, there we go. So now doesn't what Marcos was saying make more sense now when you look at that? But you just put them on their hands and knees, and then just see if you can put just have them drop their tummy down. That's going to help it move forward. And this would be a really light thrust, really light.
And you wouldn't go too I to S with this, right? Just because.
Right.
More just P to A.
Yeah. Right in the middle. Just let it kind of get the motion started and let it move the rest of the way on its own. That way. What do you think about that scoliosis?
Well, could be coming from 4.
We got some degeneration going on in here. Even 9, 10. This should be 11, I think, right there. One, 12, 11. So I'm going to say that I think some of this is because the patient might be acute based on how those discs look. So I know over time, when this gets better, this may drastically change on how much of this is actually in there. But it looks like they were getting a break right there. Looks like that was about T8. What do you think of that cervical spine there?
Straight could be.
It's actually worse than straight, isn't it? Look at that backward.
Yeah.
Look at that backward curve there. So 7 is posterior. Looks like the most posterior right there. Looks like their break is either at 1 or 7. Have to decide if they trust where they put their mark, right? 7's posterior, 6 is posterior, and that's probably as high as you would ever want to go, and that's even iffy if you'd want to get up that high. All of this is no man's land. Now you can look at that C2. That C2 looks posterior, but I'm going to say that's compensation, just so that person can get their head level to the horizon. Let's see what they do with their lines. They didn't list anything down there. I'm not sure what PRIM stands for. Is that for 4?
I don't know.
Yeah, I don't think they knew what to do with this situation. They weren't quite sure how to deal with it.
So it looks like their break was that what? Is that L4? That tiny one? Maybe 3.
Yeah, it's above the 4. There's 4. There would be 3.
Yeah.
See, as far as disc spaces in scoliosis, this one looks the worst. They've got it marked there. That's L2, but they don't have it marked here. Let's see, looks like they've got C7 crossing, but they didn't list it. They're marking T3. So they must have felt like this stacking here was where they should be starting.
Yeah, this is kind of interesting, this x-ray, how they did their lines. I'm sure the history would help a little bit, but
yeah,
because if they're not acute, I would think, I don't know.
You would think there'd be something going on in the lower back.
Yeah.
That's going to be creating all of this.
Seven AD, maybe.
Did they do that right? Should we figure out the MD80, see if it's right?
Let's do it.
So PI2, IN2, is that a married or a mixed listing?
It's mixed.
Okay, so you'd subtract them, right? So you'd have 0 times 40% is 0, right?
Yeah.
So basically, if the MD was 6, shouldn't the AD be 6 as well?
Yeah.
I'm not sure why they changed it a millimeter, but
So would this person maybe need a heel lift?
I know, because look, you would never. Well, we said that was a PL, didn't we?
Think so.
And to me, 4 is not PRI, it's PLS. 3 is PLS. So you're never going to put a lift on the side of spinous rotation. It's on the side of body rotation.
Yeah.
I think if you put a lift on here, you're just going to jack that up, and you're going to make it worse.
Mm-hmm. It doesn't look that drastic on the film, though, to have it that much deficiency. Does it? I don't know. Maybe I'm...
Oh, yeah, we were trusting their measurement. Yeah, who knows that they measured, on top of this green line, right?
Yeah, because it looks pretty. It looks a lot closer than a 6. Maybe.
Yeah, we were just going to go by their numbers just to calculate it. All right, well, what do you think? Have you keep going or have you had enough?
Only 8:15.
Okay, I'll keep going. Let's see here. Which one am I on here? Here's a good one.
Spondy.
Yeah. So you can see grade 1. Looks like they're getting a reading down there. Sacral segment there, maybe too.
Those discs are nice and plump.
Yeah, just a bad one down there.
Yeah.
And let's see, what do we have? We have
PO.
1, 2, 3, 4, 5. So the spondylo has a bifid spinous, right? And look, that first sacral segment looks like it's kind of transitional there, doesn't it?
Mm-hmm.
Because this would be L5.
So they have spina bifida and
Yeah, so there's the BB, right?
Well, couldn't it look like a spondy just because it's spina bifida?
Well, you can take your obliques or you can take L5S1 spot, but that looks suspicious to me right there. And it looks like there's a break in George's line right there.
Yeah. I just didn't know if a spina bifida would also present as a spondy if there is no pars fracture.
I don't think, if there's not a pars fracture, I don't think you're going to see any anterior translation.
Okay.
But boy, you better be counting right here. So there's 12th rib. 1, 2, 3, 4. We're saying 5 is bifid.
Mhm.
And then there's S1 that looks transitional. But right there would be actually the bottom of the sacrum. The sacral base is here, not here. Because this is that transitional segment. Everybody see that?
Mm-hmm.
Trying to just draw on the outline of the SI joint on the right there. There's the ala right there. There's the base there. The other ala on the left. And then the left SI. This line right here is actually the line between S1 and S2. Right through there. What do you think of that?
That's kyphotic a little bit.
Patient has
See what-
some defect.
See what C2's doing there? So you'd be going all the way down. Is that 7?
6, 7, right there.
Yeah, looks like 7, T1. See if you can come up with a listing with 7.
Looks like you can see the left pedicle a little bit better.
So which direction of rotation are you thinking this is?
PR. I was thinking PLI.
Is T1 not PR though?
Yeah, T1 is PR. PRS probably, correct?
Yeah.
So it looks like right at 7 is still PR, but then maybe the wedge is on the left. 6 looks like it's on the left, and then look, see how the head tilts to the right? Like that?
Yep.
So you might be able to take this on the left lamina. So this one, it may change from visit to visit, whether it's a spinous contact or a lamina contact. But remember, on the lateral, the most important part of that one looks like it's the posteriority, doesn't it? Because look how inferior your 6 is. Oops, sorry. Trying to find the lines here. There we go. Can you guys see that okay?
Yep.
Well, they're marking that S1, or I mean the S2 tubercle for the S1, S2 space. They're not making a comment about L5.
They say grade 2 spondy
Where do they say that?
on the lateral.
Oh, there it is. Okay.
Yeah, so they said even more than what you said.
Yeah. They're not even listing a cervical. They're staying way down in here. I think they're too high there, and they should be down here. Leave that one alone and start looking for something in here.
It was T7, that one.
7, 8, yeah.
So what happens if you don't get a break there? And say
Don't
you're
adjust it.
so you're sure that the break's at T5, and you see on the lateral that it looks like T7 would be, or T8 would definitely be the more structural adjustment. Would you think to stay at T5 or go down to T8?
I'd really double check my instrumentation.
Okay.
Let's do another one here. I don't think I've shown this one.
Arthritic SIs?
What's that?
How come the SI joints kind of look really kind of wavy more than all the other ones?
Oh, that's not unusual to see that.
Yeah.
What do you think of that cervical curve?
Not bad.
Not bad, right? Not bad. Probably this one right here. What is that, C5? Potential. Maybe 7 a little bit. But look at this dorsal.
Flat.
Yeah, that disc looks injured, doesn't it?
Mm-hmm. So how would you set that? If there's not really a disc there.
If there's a reading there, you can set it.
But I'm saying, you're not really lifting too much then, right? Because it's not like you're trying to set it over a disc or close it down.
You just want to follow through the plane line. Yeah.
Mm-hmm. That's pretty straight, just P to A.
Yeah, it could be this one too.
Yeah, that's what I was just... When you turn it over, that one looks more...
Do you think those discs, the vertebral bodies, are actually fusing?
Well, there's probably some tipping. We'll have to go back and look at the A to P. So some of that, what you think is fusing, it might just be more like an hourglass effect.
Okay.
This really isn't a good one to show you in the lumbars, I don't think. Here it is, yeah. So see how you're seeing on this one, the top and the bottom of that vertebrae?
Yeah.
Yeah. That's what
But
hourglass
did she have a scoliosis in her thoracic?
Yeah.
Guess a little bit.
Not so much in the thoracics, though. After having such a drastic one in the lumbar, it looks like.
Yeah.
So what do you think with that? Normally, doesn't the thoracic and everything else follow and be very scoliotic? Looks like the thoracic just straightens out completely after the lumbars.
Yeah. And it happens that way. You don't have to have 3 and 4 compensations. So we thought, what, T5 or 4?
I think 4 and 5.
So I think that's T5 right there. Looks like you could be on that right transverse, doesn't it?
Doc, have you ever heard of the terminology as to side slip?
Yeah.
What is your take on that?
I've usually, if I found side slip to be a problem, it was in a scoliosis, typically L3, L2, like you see here. There's some side slipping going on right there at L2.
Yeah.
Right, so if you try to just push that P to A, see how you're going to make that worse?
Yeah.
You got to pull it around a whole lot more. And you'll see that same kind of scenario. If it was in the dorsals, it's typically around 9, T9, T8. Yeah, you can make a scoliosis patient worse really easy by bad line of correction on the right bone.
Mm-hmm. How do you go about setting that in the chair in the upper dorsals? Like a side slip if it was present at T1, T2.
I would just make sure that I try to bring it around and back to the center.
So your line of drive is more kind of lateral to medial than a...
Well, the way you turn the head is going to be helpful, right?
Mm-hmm.
So so on a dash listing, you're gonna turn the head away, aren't you?
Yeah.
Yeah.
So doing these in the chair and the bench are more... You would rather do a side slip on those as opposed to just the knee chest where you can't position their body to help you.
Yeah, it's harder to do it on the knee chest side slip.
Yeah. Okay. Thank you.
Even on the high-low, it's
Just
for scoliosis patients, it can be tough. Yeah. Let's see what they did with their lines.
I'm wondering.
Okay, so they listed L5. We didn't talk about L5. Let's look and see what they did and see if you agree with that listing.
Is
I don't think it's rotated left.
Is the M to kind of take away the rotation of 4?
Okay, so remember what I said to do. You look at 3 things. You're looking at 5, you're looking at the sacrum, and then you're looking at L4. So first, just look at 5 and its relationship to the sacrum. Does that make sense?
No.
Yeah.
I mean,
Could it be that the lines are off?
Yeah, I was hoping somebody would see that.
It's
I was hoping you'd
too
see
much
that.
to the left.
Yeah, this line is way off, isn't it?
Yeah.
Because here's the SI joint right here.
yeah.
Mm-hmm.
That's way off. So I don't believe this rotation. Because I'm pretty sure looking at 5, looking at the facet and the pedicle of 5, that's PL, and then this would have to be a P-R sacrum for L5 to be a PL, wouldn't it?
Yeah.
Yeah. Okay. So good. So I think it's PLS for sure. Is it PLS-M though?
No, because the wedge on 4 is on the left. It'd be PLS spinous.
Yeah, I'd agree. And there isn't even much of a wedge on the right of 3. Most of that wedging, that convexity you see, is way up here on L2. So that L2 doesn't decide what L5 listing is, does it?
No.
It's L4. So that's not a dashed listing. I can keep that as a PLS. If for listing sakes, that does not mean that I'm going to adjust it, but it is a little posterior inferior there. I would even say there may be some malformation. Look at the height of the body on the left. It looks longer than the height of the body on the right.
Do you address it any differently if you think it's malformed?
I just make note of it because then I know I'm not going to change that. That's always going to be a PLS, probably.
So then would you try and adjust it? If there was a break and everything there.
Oh, yeah, if it's subluxate, I'll adjust it, absolutely. Not too bad of a neck. Little problem going on here at C5.
We probably wouldn't even touch the neck unless there was a pretty significant problem there, right?
Yeah. I was just saying it looks like 5 is maybe I don't know, I can't remember what I said before. If I thought 5 looked suspicious, but I'm saying it now, I see it.
You did say that.
Okay. And then we were looking at this T5, weren't we?
Mm-hmm.
What did they do? They
I
have
put a thing there, but they said F, so I don't know what that means. If that means like fracture or
Probably freckle.
freckle.
okay.
Yeah, there's definitely a problem in this joint. In this one. And I think this big curve up here, that's all compensation for what happened down here. I don't think I showed this one yet. I did want to show it.
No.
So what's the first thing you notice on this patient?
Big.
Big, yes, big.
And almost no teeth.
A lot of hardware.
Yeah.
A lot of hardware. Bad neck.
Mm-hmm.
And hyperkyphosis. In the thoracic.
Yeah, so you know what makes patients like this really fun? They've got a lot of adipose to palpate through. They got a really bad disc, multiple bad discs, and their neck is really short, and so it's really hard to get where you need to get.
Yeah.
They are a treat, let me tell you.
Would your finger even reach the spinous on this guy or girl?
Well,
That's a long
there's gonna be some tissue distance for sure, right? You can do it, but you really gotta work at it. Yeah, so this person's really heavy, so considering that, it's not a bad picture on the lateral. The A to P is a little rough in that lower abdomen, but boy, I'm sure this patient was pushing 300.
Yeah.
If not more. You can see the atherosclerotic abdominal aorta there.
What's the limit for putting a patient on the high-low without breaking it?
I don't know. I never did it. I never broke one, thank goodness.
I
can get a guy that's like 400 on there, so.
Okay.
And he has an old one.
Okay. So let's make some decisions here, just kind of the anatomy we're seeing. How many lumbars do we have here?
It looks like a little more. I thought it looked like 6 maybe.
Something transitional is happening here, isn't it? On the A to P?
No, it's just straight.
1, 2, 3.
All right, let's count. So there's the 12th rib. 1, 2, 3, 4. That 5 there. 6. Do we have that many people with 6 lumbars?
Yeah, it looks common tonight.
6, 5, 4, 3, 2. Yeah, 1. There's the 12th rib, right? Am I seeing that right? 12th rib. 1, 2, 3, 4, 5, 6. So that freckle, if we look at where it is there, whatever that is right on the spinous of this one. So that's got to be, let's say that's L5. There's a spinous of 5, right? There's the one below it. 6, 5, 4, 3, 2.
So if you got a bad picture like this, would you just expose them again, or would you just kind of try and roll with this?
If I can't see what I want to see, I'll take a spot shot.
Yeah.
If I wanted to see this anatomy better right here, absolutely.
Mm-hmm.
Wouldn't be a bad idea, right? Because we don't know. It almost looks like both transverse processes are spatulated on both sides. At least on the left side. Maybe it's okay on the right, but something doesn't look right on that left side.
Yeah.
It looks like you can even see a little bit of a foramen right there.
Doc, what do you think when you see like this L4 here, how much rotated it is to the left compared to 6, 5, and 3? What does that tell you about L4? Does it tell you anything special or just that it's PL?
Well, on the lateral, look how much thinner it is than the one below it or above it.
Mm-hmm.
So that's got to be related to the person's weight, right?
Yeah.
But you were asking about the rotation, huh?
Yeah. Just hit L4 on this. Maybe I'm seeing it wrong, but it looks very rotated compared to the rest of the surrounding structures.
Yeah, I think you're seeing malformation in here.
Okay.
Because look how malformed L6 is.
Yeah.
And see, look at the spinuses, how there's such a quick transition from left to right, isn't there?
Yeah.
Yeah, so I think, this would be a good picture to take a spot of that. Or retake the whole thing and use different technique. But, even the cervicals here are tough to see listings in here.
Yeah.
All right, so let's see. What are we gonna list here?
Sacrum looks kind of funky, doesn't it?
What do you think about that disc on L5S1 too?
Very thin.
Is it parallel or is it open in the back?
It looks like wavy.
Yeah.
Yeah, you might want to get another spot of that too, right?
S3 caught my attention. I don't know why.
You like S3?
Yeah.
1, 2. This one right here?
Yeah, that one. I don't know if you thought anything about it. Maybe it's just...
I don't know. It looks pretty level through there, but I think I see what you're seeing. Yeah, you'd want to take another picture of that, spot shot that.
Mm-hmm.
Do a lateral sacrum.
Even his coccyx is anterior. Look at that.
Yeah. That wedge right there, right?
Yeah.
Probably from sitting a lot.
So what do you want to do? What do you want to list here? You S3. What? Anything else?
I mean, maybe that 5 just from all the end plate hibernation.
Okay, so remember, this is L5,
Or
not
6.
this.
Yeah.
Right, so are you going to list L6 or L5?
6.
6, okay. Well, looks like there's the spinous, there's a pedicle, and somewhat of a pedicle there, hard to tell.
Mm-hmm.
Sacrum, looks like there might be the center, S1, S2 right there. There's the right margin. It's like right about right there is the left margin. So body rotation would be on this left side, wouldn't it?
Yeah.
Okay, look away. Okay, so what do you think rotation of 5 is then?
PR.
PR, okay. But what's L4 doing?
Well, that's 5.
Oh yeah, what's L5 doing? So actually we're going to list L6 as if it's L5. Sorry. So we're calling it a PR. L6 is a PR what?
P or S?
It's a
Say maybe a PRI.
I was thinking it was a PRI. So does it stay a PRI or does it become a PRI-M?
I would say stay.
Yeah, PRI, doesn't it? But I want to get a better look at what all of this looks like right in here.
Mm-hmm.
And I don't know, looking at that disc, if that really palpates, you know, if that's going to really palpate like a posterior L5.
Yeah.
It's thin. It's a thin disc, but it's close.
It's thin but parallel.
Yeah.
What about that TL junction? That one that you were saying before, how there's no there. Oh, 2.
So let's see which one that is. 6, 5, 4, 3, 2. There's 1. So yeah, 2. 6, 5, 4, 2. Now we've got rotation on the left, PLI-M on L2.
Mm-hmm.
What do you think about those dorsals? Messy.
It's hard to make them out.
Okay, fine. They look fused.
Yeah, because look at the A to P. You can see all the arthritic connections along the capsule of each disc and along the ligaments on the bodies.
Yeah.
Plus, there's a lot of blood vasculature that is overlying it that looks like it might be a little calcified.
That's what you'd show the aorta.
I wonder if this person's a smoker.
Possibly.
Plaque.
Yeah.
And being overweight doesn't help. Probably not the best diet.
No. This person would be definitely at risk for COVID, right?
Yeah.
So let's do some counting here. Thinking maybe T8. 8. There's 8. They've got a BB up here on, it looks like maybe that's 7. There it is right there. Five, 6, 7, 1, 2, 3, 4, 5, 6, 7. Yeah. So it looks like they want to list T7. How would you list 7?
PRI. Looks like the pedicles are a little bit bigger on the left side.
Yeah, PRIT.
Okay. Yeah, so don't look at all of this up here, right? That might influence, not wanting to be on this left side. You see what I'm talking about?
Yeah.
Yeah, you see this convexity to the right would make you think you want to stay on the right, wouldn't it? But not according to the next two above it. So right here is where it's compensating again. So you should be okay to be on that left side.
Mm-hmm.
Was anybody thinking about that? Or was that just me?
I think we were earlier, but when we mentioned the lower lumbars, how it's just really about the one above, I think that helped a lot.
Okay. What are we going to do with this neck?
Six.
Seven looks parallel, doesn't it?
Mm-hmm.
But boy, 6 is not good. Makes you wonder if he has any radicular symptoms, huh? Look at the degeneration around the IVF.
Oh yeah.
Looks like a beak or something. It's like this.
Big spur. All right, let's see what they did for their lines. Well, they listed 5, but they...
Not 6.
Or they listed 6, I'm sorry. They listed 6, yeah.
Well, they put 5. Maybe.
But they put 5, yeah, so they're off, aren't they?
Mm-hmm.
They missed it.
Yeah, because they're saying that the T12 is one without ribs on it. Which is kind of weird.
Yeah, find the rib. And a lot of times, too, that...
yeah, if you look on the A to P.
Yeah. Right there.
Yeah, they literally labeled it T11.
Yeah.
They said it was PLS, too. Didn't we say PR?
I thought we said PRI.
Yeah.
Yeah.
It doesn't make sense with the sacrum.
Yeah, see? Yeah, this just doesn't make sense. So, yeah, look how far off he is here. We were saying the lateral edge of this sacrum is about right there.
So you're kind of saying that they're falling more onto the ilia than onto the sacrum when they're
they're on they're looking at the line of the on the ilium of the joint, not on the sacrum. That tells you how if you want to be able to trust your line drawings, you have to be able to make sure you're on the right landmarks.
Can we look at the leg length too? Because that looks like they messed up also.
Well, it looks like quite a bit of a deficiency, even with their broad lines. So there's not much of a misalignment of the pelvis. They're mixed. So if we trust what they measured there. They marked this, but they didn't list this. They marked T1. It looks like something is there. I thought maybe that was where they were getting their break. So if that truly is where the break is, that'd be C5. 6 is going to be just lower, right on top of 7. Did we come up with a listing for 6? I don't think we did.
No.
How do you want to list 6?
It looks like
PRI
Yeah.
dash L.
I got 6 way up here. Here's 6. 176. You think you guys want to be on the left side?
On the left.
Okay.
Yeah, the wedge looks like it's on the left.
It kind of does, but I'm not convinced that I'd be on that side. That I might want to stay on that spinous because of how it looks here.
So then what are you addressing then? Just the rotation and lifting it?
Posteriority. Yeah.
So you're not trying to close the wedge down initially?
No, I want to lift that thing up. And I don't see a lot of head tipping one way or the other.
Are you changing your contact, like where you're contacting on the spinous? So instead of like more to the right, would you be more kind of under it and like in the middle in this case?
Just right where I got my pointer.
Okay.
Unless it really palpates that I need to be on this left side. But even if I'm on the left side, this is where I'm at right here. I'm not out here.
Mm-hmm.
You know? I'm still right in there. And it's easier to get a hold of it here than it is here. All right, guys. Well, it's 9 o'clock.